So for those of you who don't know Professor Mike Wilson, another gentleman who has had an extensive career and has done some amazing things throughout his career, although I know he'll sit there and deny it. But Mike Lewis is the Emeritus Professor at Cardiff University. He's held a number of senior professional positions, including Professor of Oral Medicine, President of the British Society of Oral Medicine, President of the British Society for Oral and Dental Research, been the Dean in the Dental Faculty of the Royal College of Physicians and Surgeons of Glasgow, and Dean of the School of Dentistry at Cardiff University. He's presently one of the 6 registered members of the General Dental Council. Professor Lewis has delivered more than 600 lectures and webinars worldwide on the subject of oral medicine, mouth cancer and infection prevention. He's the author of the best Line medical textbooks. Sorry, that's got mixed up in the text there. That was my bad pronunciation. Mike, I'll let you cover that one. But he's the author of the best medical textbooks, a handbook of oral medicine and the BDJ clinical guide, oral medicine in primary dental care. So Mike, I'm going to hand over to you. And thank you very much for presenting at the Professor Island annual lecture.
Excellent. Thank you, Fiona. Yes, I was, before I started, I was just reminiscing with Bob's stories there. I think the only time I involved where I battled to give a talk was about 30 odd years ago, was from Glasgow. And I went to the Dundee Dental Society, and they held the meeting in November, and there was snow everywhere. And I managed to battle through to the Queen's Hotel in Dundee, which was opposite where the dental school was. And in fact, the person who invited me and I were the only people that made it. Everyone else didn't bother coming because the snow was so bad. But that was my dedication to the dental education at the time. So, and also Bob mentioning carousels. I remember the carousels that we used to cart around when we had dual projection. We'd have 2 carousels, and those were the days. And of course, the luxury of PowerPoint now has really removed that and some of the anxiety about presenting. Anyway, back to what I should be talking about, and what I was asked to talk about is, so just how good is your oral medicine? And those that know me know I love a quiz. So, whoops, let's just move down the slide here. Hang on, there we are. So I love a quiz. So what we'll do is 10 clinical cases to get you thinking. And this was this is a path, the old railway track, the back of my house, which is the 2-meter rule. And that's in lockdown when we were, there was a 5K run down there, and somebody had put ever so often the 2-meter rule to help the NHS. And I must say, when lockdown came on, what was it, March 24th, 2020, the oral medicine clinical service stopped, and I went back to the emergency dental service, and we were doing it 7 days a week out of the hospital. And I saw dental disease I had not seen since my days in Glasgow, and it was really brought my feet back down to the ground, with a number of people presenting with huge abscesses and dental neglect. I don't know what category Bob would have put them in. They were certainly red. And it really was an eye-opener for the 5 months that I ran that service before returning to oral med. Anyway, so as was said at the beginning, for those who logged on, you need a pen and paper when I'm around. So a pen and paper just to keep score of the ones you get correct. And I say we'll look at 10 different clinical cases. And sometimes I'll ask you maybe what the diagnosis or what the cause is, or what the treatment is. So let's have a look at number 1. So this lady's in the dental chair, and you're with you. So this 55-year-old lady has gradually developed a dry mouth. And we can then see here the consequences of not having any saliva. When people say to you, what are the functions of saliva? Well, one of them is actually reducing the risk of dental caries, of course. So this poor lady has got a dry mouth, which has gradually developed. So the first question is, to get your thinking caps on, is what could be the cause of the reduced salivary flow? Now, so why is this lady not producing as much saliva as she should be or used to be able to do? And there are basically about 4 main causes of dry mouth. So if you see one of your patients there and they've got a dry mouth, there's probably 4 basic reasons why that person might have a dry mouth. Because obviously, if you can find out what the cause of the dry mouth is, and on some occasions, it can be corrected. So causes of dry mouth, and you can see the dental caries, cervical caries, and that some of the teeth have been so carious they've in the lower jaw there that they've broken off. So causes of dry mouth, or as the fancy medical term would call it, xerostomia, if we want to be medical today. But dry mouth. So hopefully if you've just written one down, and we'll see whether you've got a point. The interesting thing is the medical profession actually is the most frequent cause of dry mouth. It's actually a cause as an adverse event related to drug therapy. So the medical profession actually induce, they provide, and I'll come to that in a moment, but drug induced. So here, the medical history of the patient might say, well, what drugs is this patient on? And you'd look, and you can see that, oh, that drug there has an adverse event, which is the proper term for side effect. The adverse event. Now, the other one is Sjogren's syndrome. And Sjogren, don't forget the little dots on his O in his name. And he was a Swedish doctor. And I often say to the students on the clinic, what specialty was Sjogren? And in fact, Sjogren was an ophthalmologist who first found patients with dry eyes. And then he found some of his patients, not only did they have dry eyes, but they had a dry mouth. And this became the Sjogren syndrome of dry eyes and dry mouth. Radiotherapy. So here we are, medicine's causing the dry mouth again here. If somebody has to have radiotherapy to the head and neck, then unfortunately, if it's there for a tumor in the oropharynx, that they've elected to have radiotherapy rather than surgery, the radiotherapy has to go through the salivary glands. And unfortunately, the salivary glands, they're not destroyed, but they are desensitized. So the neural stimulus to produce saliva doesn't get through. So they're not destroyed, but they are deactivated in radiotherapy. And the one that a lot of people forget, and is becoming more frequent though, is undiagnosed diabetes. If you have high sugar levels, then your urine production goes up, and so the urine output goes out. And then if there's not, if it's not compensated by drinking water, then the patient will get a dry mouth. So undiagnosed diabetes, particularly the maturity onset diabetes, type 2 diabetes. And it's always worthwhile asking the patient, have you had your blood sugar checked? Has the doctor done this on a routine basis? Or have you been to the pharmacist and get it checked? So what would you do is give yourself a point for any of those: drug-induced Sjogren's, radiotherapy, and undiagnosed diabetes. And in fact, that particular lady actually had undergone radiotherapy, and it was bad enough because she had oropharyngeal cancer, which was treated. But then that's bad enough, and worried. But she all then was distressed, of course, because she's losing her teeth. It was a bit of a sad case, actually. Right. So these are the drugs. If you look at the medical history, then tricyclic antidepressants, the tricyclics, the things like amitriptyline, nortriptyline, these are well-known drugs to cause dry mouth. The antihistamines, diuretics, some of the antipsychotics. And what happens is that these drugs block the stimulus to the salivary glands. You've got maybe your carotid glands, your big salivary glands, your submandibular glands and sublingual glands. Salivary production is under neural control, and therefore, moving that up here, right? Is under neural control, but the thing is, the drugs block the stimulus to the salivary glands. So this is one of the ones where occasionally, if the patient has said, yes, it's all started after I started these drugs, well, the medical practitioner can be asked, well, can you do an alternative antidepressant or an alternative drug? And there's the signs of xerostomia. sticky, bone dry saliva, bone dry, palate, bone dry tongue, a little bit of sticky saliva hanging from the palate there, but a dry mouth and more dry mouth here. And any of you who've suffered a dry mouth occasionally, you know how uncomfortable it can be, but these poor patients with persistent xerostomia have that problem all the time. So, as I mentioned, the functions of saliva, one is to clean around the teeth, physically washing debris away, but also there are chemicals, bicarbonate in saliva, that will neutralize any acids. So the pH is brought up. So the negative pH, the low pH is brought up by the bicarbonate, so you don't get acid erosion on the teeth. But the management of xerostomia is not easy. I will say that. People have spent a lot of time, and companies have spent a lot of time producing artificial saliva, salivary substitutes. And it's all well and good, but they're expensive and they actually don't last that long. And it's actually far better just to have frequent sips of water. So frequent sips of water is probably just as good as having something like saliva or Thana. And although having said that's all right, that's at home. But if somebody goes off down the shops or something and they want to take something with them so they can be able to speak to people in the shop or people they meet, then these little salivary substitutes in sprays are quite helpful to have in the pocket to help speaking when they meet people. And then there are salivary stimulants, and these are quite good. These are things that will stimulate the salivary gland, because the salivary glands aren't destroyed. There'll be some functional salivary gland there. And if by the act of chewing, then that fools the salivary gland that you're eating, and it will make saliva for you. And obviously not sugary sweets, because you don't want to be putting sugary sweets in, because that's going to encourage any caries. So sugar-free sweets, diabetic sweets, sugar-free chewing gum, these little salivary chewing tablets. So to stimulate the functional salivary gland to make saliva. And here we are, an effective toothbrush is good. Now, people with Sjogren's syndrome also have rheumatoid arthritis in their hands. So if you say to somebody here, look, you've got to toothbrush and you've got to floss and you've got to do interdental cleaning, that can be very difficult for patients with Sjogren's where there's rheumatoid affecting the hands. So this is where some of the power toothbrushes come into play, and that happens to be an Oral-B Genius in black. And I don't know, not that I watch it, but some of you, if you watched Love Island last series, the company product placed the Oral-B black toothbrushes. All the contestants had Oral-B toothbrushes, if you noticed it. Right. And other measures, interdental cleaning, fluoride mouthwash, a daily fluoride mouthwash to protect the teeth from the acid attack due to the lack of saliva, and a fluoride toothpaste, all good stuff, to try and minimize the impact of the lack of saliva. So that was dry mouth. I'm sure you must see patients with dry mouth. And I see the one that's often forgotten is the maturity onset diabetic, those patients in their 50s who are suddenly developing a dry mouth, and ask them, have you been checked out that you haven't got type 2 diabetes? Right, change of tack completely now. These white patches, bilateral and symmetrical, and have been present for many years, and they're just noted whilst doing a soft tissue exam around the mouth. I will actually ask you, what is the diagnosis? Have you seen this condition that gives, it's lacy white lines, and you look at in the right buccal mucosa, and you're assisting and helping and looking, and you say, oh, there's the same over the other side. It's almost like bilateral and symmetrical. And sometimes the patients might not know they're there, and sometimes they will say, yeah, I get a little bit of soreness from time to time. So what is the diagnosis? This is a beautiful example, obviously, of this condition. And we see it frequently on my clinics. I'd see 4 or 5 patients on a clinic with 28 patients, and 4 or 5 of them might have this condition. So what is the condition? You can be right. Oh, here we are. Thank you. Stephanie's just banged it in the chat there. Stephanie, you are correct. You've given us the condition, lichen planus. Because it's a Saturday and I'm a generous chap, if you put LP, I'll give you that. I don't normally like abbreviations, but if you put LP, I know what you meant, lichen planus. So, lichen planus, and there's some beautiful South Wales lichen planus, bilateral and symmetrical, and I could just sit and look at that all day. It's just fantastic. But we won't, because we've got to move on. And it's reticular, which means lacy, and erythematous, these red inflammatory changes in the mucosa. And the most frequent place to see it is inside the cheeks, the buccal mucosa, on top of the tongue, or actually on the attached gingivae. And I'll show you pictures just now. So there's on the attached gingivae, this redness, and you might be thinking, well, this person's got gingivitis because they don't clean their teeth. But in fact, this lady cleans her teeth fantastically, but her gums are still red, and they're red because she has this inflammatory condition called lichen planus. And it may last many years, as you will see in the next slides. It can last a long, long time. We have patients who, for many years, will have lichen planus. I've been in Cardiff almost 30 years, and occasionally a patient will come from more than 20 years ago and re-present with lichen planus from all those years ago. It's not that they've suffered through 25 years, because the condition can go into remission and we can treat it, and it disappears, then suddenly it will flare up again. So it can be there a long, long time, and it may change with time. And this lady here, now you see these lacy white lines on her tongue, lichen planus. But in fact, these pictures were all taken about 2 months apart. And then it went, it flared up, and it let her know it was there. It's an immune reaction. It's a bit like it's not quite a hypersensitivity allergic reaction, but it is driven by an immune response. And it settled down a bit for a few months. And then, oh dear, it flared up again for a few months. And I'm giving her all the treatments that are available, trying different treatments. And eventually it did sort of burn itself out, but it can be really problematic. So I said it's driven by an immune reaction. So how are immune or inflammatory reactions treated? Well, steroids. Topical steroids are great drugs, and they're great anti-inflammatory agents that will calm down an inflammatory reaction. And there are little preparations, the hydrocortisone is little buccal tablets allowed to dissolve in the mouth. Or the inhalers that the same inhalers that are used for asthma, lots of people use. You will see in another case coming up, lots of people use inhalers these days, but the steroid can sometimes can be used to treat oral lichen planus. Right, let me just get down here. And here we are, a beautiful bilateral and symmetrical lichen planus as it came to me, but let's spray some steroid on it, okay? So let's go, woo, that's great, and woo, let's do it on the other side. And that's not Photoshop, it's not me just rubbed them out in Photoshop, that's a real clinical picture. And you can see how effective the topical steroid treatment can be. Like that, gone there. And that, when it's inflamed, it does give the patient discomfort. Some cases are challenging. This lady comes from North Wales to see me in South Wales, and she's been one of my more challenging lichen planus patients. But we made a soft splint, one of these, there's like the sports guard, and we can put the steroid in the splint and hold the steroid on the tissues, but they can be quite challenging. And I'm always asked, what about lichen planus and mouth cancer? And I must have, in my 35 years working in oral med, I must have seen thousands of patients with lichen planus, and I can almost think the ones that have developed mouth cancer, I can almost count on perhaps both hands and some of my toes. It's a very, very small percentage that go off. This, though, was a gentleman who went off, and he blew up into that. Now, these pictures here, I'd been seeing this gentleman for about 10 years, on and off with his lichen planus. And one day he came and said, "Oh, Professor Lewis, I think it's bad today." He came in and he'd booked to see me earlier than he should have because he was concerned. These two pictures were taken 8 weeks apart. Bang. Because it came back early because it had blown up and he developed a huge squamous cell carcinoma. But that is an exception to the rule, because don't freak out, or if you know people who've got lichen planus, don't get really worried about they're going to get mouth cancer. It's the minority that develop mouth cancer. Okay, let's go to another case now. White patches, easily removed and diagnosed as thrush, or to give it its proper name, pseudomembranous candidosis. And what could be the cause here? Why would a patient suddenly develop this type of infection? What's the cause of the infection? So what sort of things? Now, because I'll tell you, we have all got candida in our mouths. Everyone has candida as part of the oral flora. But what sort of things can let those candida multiply and let you know they're there? Right, okay. So candidosis has been called the disease of the disease. It's an opportunistic infection. So what sort of conditions, or what can happen to the patient to allow the candida that we've all got in low numbers in our mouth multiply to let us know it's there? Pregnancy. There's an increased incidence of candidal infection in ladies who become pregnant. Local trauma, denture design and denture hygiene. One of the most common forms of oral candidosis is that under a denture, because candida love living on the plastic of the denture, and they cause an erythema in the roof of the mouth when patients wear the dentures all the time. They don't take them out at night and they don't clean them. Antibiotics, somebody can get a sore mouth when they take an antibiotic, say an antibiotic for an infection on their toe or anywhere else, but in fact, the antibiotic reduces the number of bacteria in the mouth, which allows the candida to proliferate. Steroids, inhaled steroids, or systemic. People are on systemic steroids for all sorts of reasons, and they immunosuppress the host defense system and allow the candida to multiply. Malnutrition, hematinic deficiency, low B12, iron, folate. Endocrine disorders, diabetes again. Diabetes giving dry mouth, but diabetes, uncontrolled diabetes, giving candidal infections in the mouth. Malignancy, blood disorders, leukemia. I've had patients present with acute leukemia, and the presenting factor or presenting symptoms was oral candidosis. Immune defects, HIV infection. We used to see, I'm going back now into the sort of late 80s when I was working in Glasgow and with a lot of patients with HIV infection. And one of the presenting factors would be oral candidosis, thrush, and a dry mouth. So there's lots of things that have to be accounted for. If somebody has thrush in the mouth, so give yourself a point, any one of those. If there's one there that somebody wants to claim that I haven't included there, or they don't think I put it on there, put it in the chat and I'll respond. But the disease of the diseased. Fortunately now, since in my working lifetime, the treatment of oral candidosis has improved dramatically. We used to have messy little topical antifungal agents that were horrible. They tasted horrible. They were horrible to use. But in the middle 80s, fluconazole was developed, which was a game changer for candidal infection treatment, because you could swallow this drug. It was absorbed, got in the blood, it got around the body, it got into your saliva, got in the mouth where we needed it, and it dramatically changed the treatment of oral candidosis. It was, in fact, developed primarily for vaginal candidosis, because you can buy a 150 milligram capsule over the counter. And the great thing about it is you get the blood levels are very high and gets the drug where you need it. In our case, in the mouth. Ones you're likely to see, the one you're most frequent is maybe sitting in the chair when you're looking in the patient's mouth, having a little look around, is in relation to steroid inhalers. The steroids are given to improve airways. Somebody will have some form of respiratory disease. But the steroid is blasting on its way. Not all of it gets down into the lungs, and some of it gets left on the soft palate. That suppresses the immune system locally and allows the candida to proliferate. So if the patients are with steroid inhalers, they should read that little piece of information that none of us do read that comes with drugs. It says, please rinse your mouth out with water after you use the inhaler to stop the risk of you getting thrush in the mouth. Or this is one of my favorite conditions here now. This man complains of his tongue, pain from his tongue or discomfort when eating a curry on a Friday night. He goes out, he loves his Thai curry, and he gets a sore tongue. The appearance of the tongue changes from day to day. Or somebody from the last one put chemotherapy. Yeah, chemotherapy. Any immunosuppressive chemotherapy will give you thrush. Right. What's the diagnosis? And one of my top 10 favorite conditions, this. And we will see this every single clinic I ever do. We see this condition. Sometimes the patient doesn't know they've got it, but that is just a beautiful example. Yes, oh, look at that. Everyone's coming in with geographic tongue. And I'm glad you put geographic tongue. Geographic tongue is the term I prefer, but it's got some great names as well. Erythema migrans or migratory glossitis, because the red glossitis is inflammation of the tongue. It tends to move around the tongue. Erythema migrans, red patches moving. And in fact, my favorite is wandering rash of tongue. You've got wandering rash of tongue. But the term we tend to use, and yeah, benign, but somebody's put benign migratory glossitis. The term I prefer is geographic tongue. There's two other geographic tongues that have come my way. Where did it get its name? And I ask the students this, and they say, oh, because it moves around. And I say, well, that geographic doesn't mean moving around. Geographic means a map, doesn't it? Oh, yeah, so it does, Prof. Lewis. Well, a map of where? Now, when they were making maps over 100 years ago, they sort of made the sea blue, and then thought, well, what color will we give the land masses? And this map was made over 100 years ago, and they used to color them pink. I know this looks a little bit red, but actually on the maps, they were pink. And it goes back to the map of the British Empire 120 years ago. And that's how it got its name, geographic tongue. But geographic tongue is great, and it's not always there, though. Sometimes, as I say, it can change dramatically within 48 hours and come and go and appear to move around. But this patient here from a while back, the day he came, it had disappeared. He said, don't worry, I've taken a line drawing. And so he gave me this picture on the left-hand side of the screen there. He said, I've drawn it for you. And I said, can I keep that? That's fantastic. He said, yes, of course you can. So I put it in his notes. And that could be his geographic tongue. But nowadays, of course, they don't have to be good artists or good at line drawing. They can whip out a fancy mobile phone that's usually fancier than mine. And they'll say, well, this is what it was like last week. This is what it was like the week before. So it's geographic tongue, 1% of the population. So it's really frequent. Some people don't know they've got it. Some people will say, yeah, when I'm out having my hot and spicy curries, my Thai curries, my Indian curry, whatever, that's when I know it's there. Now, in some books, they would say, well, tell the patient it's not infectious, reassure them it's not malignant, they haven't caught it, they can't pass it on, and go about their business. But we did think that was a bit unfair. And so we developed in Glasgow many years ago, before I've been down here 30 years in Cardiff now, zinc sulfate. Now, this isn't on the dental formulary, so the doctor would have to prescribe it, and you can't buy it. But a zinc tablet. So if you know anyone with a geographic tongue, they can dissolve the little zinc tablet in water and use it as a mouthwash. It's dissolved in 10 ml water and used as a mouthwash for 2 minutes, held in the mouth, then spat out. You don't need to swallow it. They're not zinc deficient, but the zinc will get the geographic tongue to improve. So I'm just going to grab some water here. Right. Okay, let's move on. Oh, here we go. A female presents with a painful swelling, bleeds easily on probing, and it had been come up over about 5 weeks, so it had come up relatively quickly. What's the diagnosis? So what's this? Painful little lump on the gum. She also had another lump. When she walked in, I noticed she also had a bump that I could see. So does that give you a clue? And the clue is epulus, correct. People are putting epulus in. Yeah, the epulus just means on the gum margin, but it's a pregnancy epulus. Yeah, its proper name is pyogenic granuloma, which sounds a little bit life-threatening and sinister, but pyogenic granuloma is its proper name, but in the pregnant lady, it's called pregnancy epulus. And unknown etiology in non-pregnant people, query trauma has been implicated, hormonal changes in pregnancy. It's a single rapid onset and it ulcerates, so it's painful. And if you tap it, it bleeds. So it bleeds on probing. It can be excised under local anesthesia, may recur. For ladies with pregnancy epulus, after the baby's born, actually, they sometimes regress anyway, naturally. So a little pyogenic granuloma, pregnancy epulus. Right, now, a pigmented mucosal change that's been present many years. What is the diagnosis? So there's a number of causes of pigmentary, localized single pigmentary changes in the oral soft tissues. But what's this one? It's not raised, is it? It's not raised, it's flat. It's a sort of slate gray appearance. What could this be? Yep. Well done, Tony. And Anna. Amalgam tattoo. Yeah, it's an amalgam tattoo. Amalgam tattoo. Remember to spell it right. On many slides I had at one time, I actually spelt it. I had one single T, but it's T-A-T-T-U-U. The amalgam tattoo. Implantation of amalgam into the tissues. Single slate gray black mucosal change. A radiograph can help your diagnosis. The important thing is you must exclude malignant melanoma. Malignant melanoma in the mouth is rare, but it is a serious condition to get. The 5-year survival for intraoral malignant melanoma is only 20%. So no active treatment required if you're happy that it's happy it's an amalgam tattoo. And here's one here. And the patient's worried, oh, look, I'm a little bit worried about this, that pigmented area, and it's been there many years. What has happened, of course, is that premolar that was extracted probably had a large amalgam in it. And when the tooth has been extracted, the person who's extracted it is very pleased with themselves. Yeah, the root's all there, the tooth's out. What they haven't noticed is the amalgam that was in the tooth has dropped into the socket. The socket then fills with blood quite rapidly, and everything looks fine. Oh, okay, yeah, that's all fine, jolly good, away you go. And it heals up. But then many months later, the appearance will come through. Now I can take a radiograph. There we are. That's the crown at the back there, the gold crown. And I can take the radiograph and I can show the metal inside the healed socket. And you can just leave it there. That's not a problem. So we go, that's there, little intraoral periapical, confirms the metal's there. We're reassured it's not malignant melanoma. Well, here's another one. This was one that was in recently as well. That's good. Right. Those were two sort of fairly rapid ones. Now let's go to this one. These ulcers develop every 6 to 8 weeks and last about 10 days. Now here, some of you listening to me might have suffered from this condition, and it is the most frequent mucosal condition. And that is just a beautiful example of it. What is the question I've asked? Yeah, come on then. What's the diagnosis? This is the most frequent mucosal condition in the mouth for the dental profession. And it's got a nice name, though. It's got a nice name. And that's just a beautiful example. It's a round oval ulcer. You can see it's a complete ulcer. And that redness round it is inflammation. That redness is an inflammatory reaction. Now, some people will say oral ulcers or apathy. But Tripat, I hope I've pronounced that correctly. Oh, you've put recurrent aphthous ulceration. Oh, well, that's a sort of split between the two. It's either recurrent aphthous. Now, remember, aphthous is spelled APHTOUS. Recurrent aphthous stomatitis or recurrent oral ulceration. Aphthous is the Greek word for ulcer. So if you say recurrent aphthous ulceration, you're really saying recurrent ulceration. So I don't mind. I prefer RAS, recurrent aphthous stomatitis, but I won't get too upset if you say ROU, recurrent oral ulceration, because I think everyone knows what we mean. So this condition, 10 to 15% of the UK population. So I'm sure somebody listening to me at the moment and with you as the audience will have suffered from this. Now, aphthous stomatitis is characterized painful. You know when you've got an aphthous ulcer. You know, sadly, you can have a big mouth cancer ulcer and not know it's there. But with an aphthous ulcer, you know you've got it because it's painful. They're round or oval. It has a yellow base, which means all the epithelium's been lost to expose the underlying connective tissue. And the erythematous, the red border, is due to an inflammatory infiltrate. And there's sensitized lymphocytes which are causing the grief. Now, there are 3 clinical types, minor, major, and herpetiform. To be honest, it doesn't really matter which one the patient's got because the management's going to be the same. But most people with RAS, recurrent aphthous stomatitis, have the minor form. And the minor are 2 or 3 little ulcers like the ones I'm showing you in the picture there. They're painful. They heal in about 10 to 14 days and don't leave any scarring. And they might not have them for 4 or 5 weeks, then they come back, and 4 or 5 weeks, and they come back. That's the recurrent nature of the ulceration. But minor are, as the name implies, small, and they last about 10 days. Major, as the name would imply, are bigger. So major aphthy are larger. They may be 1 centimeter, 2 centimeters, as the one I'm showing you there in the soft palate. They're bigger ulcers. There may be 1, 2, 3 at any occasion. They last much longer. They will last about 6 weeks. And because of the prolonged nature of the ulceration, they heal with scarring. So hopefully, see, that one healed, but can you see the scar, the whiteness in the mucosa? And I'll just take you back that's the ulcer. We sprayed some steroid on it, and I'll come back to that in a moment. But spray that on, and that heals it, but it heals with scarring. And then the final one, herpetiform, which about 10% of patients have multiple ulcers because it looks a little bit like primary herpes, which I didn't put in today, I haven't got time. But primary herpetiform means you could have 15, 20, 25 ulcers, multiple ulcers at the same time. Painful or all painful, and then they heal within 10 to 14 days. But as I say, it doesn't really matter. Anyone with a recurrent history of recurrent oral ulcers that look like that have aphthous stomatitis, and the diagnosis can be made by the clinical history. They come and go, and the clinical appearance. So we get the diagnosis. That's the easy bit. Because when patients get referred and say, oh, I know what's wrong with you. Oh, what's that? Recurrent aphthous stomatitis, recurrent oral ulcers. And I say, don't panic. It's not serious. But the diagnosis is easy. The management can be a little bit trickier. Now, somebody with recurrent aphthous stomatitis or recurrent oral ulcers, have they got restricted dietary intake? Are they strict vegans or vegetarian? They're not getting iron in. So do they have restrict dietary intake? Do they have hypersensitivity reaction? And some people can have certain food stuff. Every time I eat such and such, I get oral ulcers. Or I changed my toothpaste recently, and I've got a toothpaste now, and ever since I've been getting these ulcers. And that's a hypersensitivity to the sodium lauryl sulfate, which is the foaming agent in the toothpaste. If they have abdominal symptoms, then you worry, is the oral ulceration an oral manifestation of some potentially sinister disease in the gut? And that's why I show you that schematic of the gut there, because there could be all sorts of things going on in the gut that are leading to deficiencies of iron, B12, and folate, which then result in oral ulcers. And obviously, people can become anemic with heavy menstrual blood loss. And then the anemia, the iron deficiency, can give you mouth ulcers. So anyone who's getting frequent recurrent ulcers needs to get the GP to do a full blood count, and that'll tell you the red cell count, the white cell count, the hemoglobin, tells you all sorts of things. But more specifically for oral ulcers, the ferritin, the iron. Don't just go with the hemoglobin. People say, oh, your hemoglobin's all right, because iron is prioritized to hemoglobin in your blood. But you can have a normal hemoglobin, but a very low available iron. And the test you want to demand is ferritin, which is a very accurate assay of iron status. Or they could have developed pernicious anemia, which is a deficiency of B12, or they could have a deficiency of folic acid. It's quite good where patients, when the blood tests are done and a deficiency is found, once you find the reason and correct it, then the ulcers usually go away. They don't suffer anymore. Now, people can have the bloods are all normal, and I spend quite a bit of time with patients avoiding these foodstuffs. There are certain foodstuffs that if you're prone to get ulcers, you will get them. Crisps. There's something, it doesn't have to just be Walker's, the one I'm showing you there, but crisps. Crisps can cause the trauma. There's something about crisp. The next thing is benzoic acid or benzoates. And you think, well, where on earth do I get benzoic acid and benzoates? Well, they're food preservatives. The E number is 210 to 219. And they're in fizzy drinks, Coca-Cola, fizzy drinks, and all sorts of foodstuffs. They're in all sorts of things like Iron Brew, Fanta, all these sort of things, 7-Up. And it's a reaction to the benzoic acid. And benzoic acid occurs naturally in a tomato. So we say to the patient, look, off the crisps, off the tomatoes, off the fizzy drinks. Now just do it. It's bad enough. The ones that refer to me get ulcers very badly. So it's bad enough for you to come to the hospital. Now just avoid these in your diet for 6 weeks and see how you go. And also, sorry, chocolate as well. Sorry about that one. Yeah, chocolate was, I knew chocolate was in the picture. And chocolate as well. Some people don't like the dietary advice I'm giving them. But that will, if they avoid these things, if I'd have £1 for every time someone's come back, I'm cured, I'd be a rich man. For those ulcers that do occur, Corcidal, chlorhexidine, remember it does also come as a spray, not just a mouthwash. And the spray is much nicer to use. You can just spray it on the ulcers. And benzidamine hydrochloride, which is an analgesic as well as an antiseptic, Difflam is a good. So spraying on the ulcers to keep them clean, they'll heal that bit more quickly. Oh, somebody's just put rocket salad leaves. Okay. And somebody's also put, is milk chocolate worse than dark chocolate? No, it's the cocoa. It doesn't matter whether it's milk chocolate or dark chocolate. It's the cocoa that it's reacting to. Hydrocortisone, we're back to steroids here again, like we were with lichen planus. That redness around the ulcer, I said, was an inflammatory reaction, sensitized T lymphocytes. Well, up to 4 times a day, you can dissolve the hydrocortisone on the ulcer and it will calm it down. Or the spray again, the spray that's used for asthma, etc., can be directed at the ulcers or prescribed to be used specifically for oral ulcers to calm it down. Right, this edentulous patient has an upper dentist, but concerned about her appearance. What microorganisms, it's angular colitis, isn't it, we've got here, but what microorganisms may be responsible? So what causes this inflammation? What microorganisms can cause that appearance at the corners of the mouth? There's basically 2 groups of microorganisms. Right. Candida, yeast candida, it's probably a candida with a denture. There's lots of candida in the mouth and they spill out, or staphylococci. remember, we've all got staphylococci on our skin, but the staphylococcus, so Candida or staphylococci, if you've got yourself a mark. Now, if there's a denture wear, it's probably Candida, because the Candida love living on the denture. So it gives them a place to live. Yes, somebody's put Candida albicans. Well done, Claire. If it's dentate, probably staphylococcal from the nose, because people harbor lots of staphylococci up the nose. And where some of you may have been getting angular cheilitis more recently when we've been wearing all these blooming masks and headgear and everything, and because the staphylococci from your nose are causing the angular cheilitis. So I don't know if any of you, in the jobs you've been working on have been wearing masks far more and all sorts of things far more than we normally do. So staphylococci, what can we do about it? There's a great cream, topical miconazole with hydrocortisone, Dactocort cream, just great for angular cheilitis. Miconazole was developed as an antifungal agent against Candida, but the great thing is it also has activity against gram-positive cocci, such as staphylococci. And so the miconazole will destroy the Candida, destroy the staphylococci, and the hydrocortisone will take down the inflammation. So Dactocort is what you need. If you've been suffering a bit of COVID angular cheilitis from your mask wearing, that's the topical agent you need. Okay, persistent white patch that cannot be wiped off. So we're doing a soft tissue exam, we're having a little look around, patient sticks their tongue out and that appears. And you think, ooh, what is that? I don't know what that is. But we use a term, because that could be all sorts of things until we know better, but it uses that could be all sorts of things. But what clinical term could you say, rather than just white patch? You could say I'm going to write in the notes or in the exam, has revealed a such and such on the lateral margin of the tongue. So what is the word that would be used? Yep. Well done, Claire. Leukoplakia, white patch. It's leuko meaning white, plakia from the Greek meaning plaque. So leukoplakia, it's a white patch. And we've got all sorts of interested. I used to do a white patch clinic every Friday morning on a white patch clinic. And I'll come back to that in a minute. Persistent red and white patch that cannot be rubbed off. Now, did I put the bit we're looking at? Yeah, there. Now, this is red and white and on the lateral margin of the tongue. What's the diagnosis here? What is the diagnosis? You could say erythroleukoplakia, a red-white patch, but in fact, the biopsy of that revealed mouth cancer. I only was putting these together, this talk together the other day for you. Mouth cancer or squamous cell carcinoma. That's not some weird Welsh spelling of carcinoma. Sorry, there's an E in there that shouldn't. I did that one too quickly. But it's a mouth cancer. And 95% of mouth cancers are carcinoma. So anything within urgent suspected cancer has to be referred, and there's a pathway. So if you think there's some mucosal change, a white patch, a red patch, etc., then patients need to be referred what's called the USC pathway. An unexplained ulcer in the oral cavity lasting more than 3 weeks needs to be referred. A persistent or unexplained lump in the neck needs to be referred. A lump on the lip or in the oral cavity consistent with oral cancer needs to be referred. And a red and white patch of the oral cavity consistent with erythroplakia, meaning red patch, or erythroleukoplakia. The red-white patches are the most worrying, in fact. So they need to be sent in, and the expectation of an urgent suspected cancer pathway is the patient will be seen within 10 days. And the importance for that is the 5-year survival of mouth cancer. When we diagnose somebody with mouth cancer, we say, well, how many of the patients are alive 5 years later? That's called the 5-year survival. Stage 1, if the cancer is detected when it's 2 centimeters in diameter with no spread, metastatic spread to the lymph node in the neck, that will give you that's a metastasis to the lymph node in the neck, 80% of patients are alive 5 years after treatment. Stage 2, it can be a bit bigger, 2 to 4 centimeters, but still no spread to the lymph node in the neck. Then 75% of patients are still alive. However, once it gets bigger and it spreads to a node in the neck, then I'm afraid you're down to 40%. And if it spreads to more than one node in the neck, it's only 10%. So 9 out of 10 patients will die within 5 years of diagnosis. So early, inverted commas, I put the word early, it should actually be small. Small diagnosis significantly increases the 5-year survival. We want to find these cancers when they are small. The reason I put early in inverted commas is not all cancers grow at the same rate. Some cancers grow very, very slowly. And some cancers grow very, very quickly. Remember that the gentleman with the cancer on his tongue with lichen. So detection of the tumor under 2 centimeters is absolutely key. Oops, right. Now I was thinking, what does 2 centimeters square look like? I'll measure my fingernail. That is the size 2 centimeters square. 95% of mouth cancers affect the lining of the mouth. They're on the surface. We should be able to see them. You should see something that's the size of my fingernail in a patient's mouth, such as that one there. Would you notice that one? I'm sure, hopefully you all would, on that gentleman that came my way about a year ago. Oops. Let's go now. So recording, one of my campaigns at the moment is to get people to stop using the word lesion. I don't think I did use the word lesion in my presentation this morning. I want mucosal abnormality. The word lesion comes from the Latin word lesionum and just simply means injury. Please use descriptive terms. It's much better to say an ulcer, a swelling, a red patch, a white patch. If I'm looking at an urgent suspected cancer referral letter and it says, "Dear Mike, can you please see this patient with a lesion on the tongue?" It could be anything. "Dear Mike, can you please see this patient with a red, white lump on the tongue?" I'm thinking that patient's got to come in sooner rather than later. So it's much, much better to use a descriptive term than the word lesion. And I've got a campaign for the abolishment of the word lesion. Photographs, somebody's I use abnormality now all the time. Well done. Well, Diane. Well done, Diane. Thank you for joining the campaign. Photographs, if you're in the practice, try and photograph everything. It makes such a difference. Anyway, I'm bang on time. Is there anyone out there with a 10 out of 10? We'll claim it on the chat line. Every practice should have this book. Somebody said that, I know, because it was me. And that's the book. There's full of color pictures and they're arranged in white patches, red patches. And so you just flick the pages through until you find one that looks like what the patient's got. I hope you have enjoyed that. A big thank you for asking me to speak at the Bob Island lecture. I'm greatly honored to do that. This was a sign made up of a pastiche of faces. They're all individual pictures on the hospital, and that's the dental hospital where I work. Just to the left, my office is up on the top there.